All right, guys, welcome back to another chapter. Chapter 15 is our injuries to muscles and bones. Here, we're going to end up talking about all sorts of different injuries, as well as some splinting and how to treat those injuries. We're going to start out by looking at the National EMS Education Standards. For this chapter, we have a trauma standard, uses simple knowledge to recognize and manage threats based on assessment findings for an acutely injured patient while awaiting additional emergency medical response. Next, orthopedic trauma, recognize and management of open fractures, closed fractures, dislocations, and amputations. Head, face, neck, and spinal head, face, neck, and spine trauma, recognition and management of life threats and spine trauma. So the introduction, EMRs are encouraged. So the introduction here, EMRs will encounter many types of musculoskeletal So the introduction here, EMRs will encounter many types of musculoskeletal injuries throughout their time. This is one of the most common things I feel like we get called for are fractures and dislocations, head injuries, spinal injuries, chest injuries. Our skeleton and our muscular systems are very large systems, and we do a lot of crazy things, so they are often injured. We need to understand basic anatomy and function of the musculoskeletal system in order to treat all of these injuries. So as we start out, we're going to talk about our assessments and making sure that we're going through our systematic assessment the same way every time. And then we're going to talk about the anatomy of the body, of the bones and the muscles so that we understand those before we move into looking at injury patterns and how to splint and treat some of those. So the first thing, this is our same patient assessment that we have in every other chapter that we're going through. We're going to start with our scene size up. Remember, this is my 5,000 foot view, where as we're arriving on scene, I want to look around, see any potential hazards, anything that might cause injury to myself, my partner, or the bystanders. Also looking for what might have caused the injury to our patient so that I can get a good idea of the mechanism of injury or nature of illness before I ever make contact with that patient. Next, we're going to have our primary assessment where we're identifying life threats, our airway, breathing, and circulation. We're forming our general impression of the patient. We move into getting a good detailed history of the events that led up to this incident, moving into our secondary assessment, looking at the entire body for other potential injuries, and then continually reassessing our patients. It's important that we complete all of these steps of the patient assessment in sequence. As we do this, we're able to make sure we're doing it the same way every time. We're also making sure that we don't get that tunnel vision. As we come in and we might see an injury on the leg, for instance, if we have an open fracture and we get tunnel vision looking at that, then we're not going through and checking our airway, breathing, and circulation first, and we may miss a potential life threat there. So as we go through, make sure that every time we do these assessments, we're doing it the same way from the top all the way through. And as we get to our reassessments, remember that if they're stable and that if they're stable and we don't have any life threats identified, we're reassessing every 15 minutes. If they're unstable, then we're reassessing every 5 minutes. So let's start talking about the skeletal system. Our skeletal system consists of 206 bones that make up the framework that holds our body in place and actually supports our movement as it's attached to our muscles. Our bones also manufacture our red blood cells. Our skeletal system is divided into 7 areas. We have our head, skull, and face, our spinal column, shoulder girdles, upper extremities, rib cage or thorax, our pelvis, and our lower extremities. It's important that we remember these divisions as we're doing our assessment, and we break them up independently as we go through and we're looking for injuries in each of those locations. Here you can see the skeleton and that breakdown of each of those locations: the skull, the spinal column, our shoulder girdle, our upper extremities, our pelvis, our lower extremities. So the bones of the head and skull are So when we're looking at our head and skull, most of the bones of our skull are actually fused together after birth. When we're younger, those bones have not fused yet. So it's important to remember anatomical differences between our adults and our children. But those bones, as they fuse, they create the container that protects our brain. Part of that The other part of our head includes our jawbone, which is a movable bone attached to the skull. Next, we have our spine, which consists of multiple bones that are separate. They each support each other in articulating the body, making it so that we can move in a fluid motion. We have 5 sections in our spine. We have our cervical spine, which is our neck, our thoracic spine, our lumbar spine, our sacrum, and then our coccyx, which is our tailbone. The lower 2 are actually fused as well. So looking at these, cervical makes up the neck, thoracic is the chest, lumbar, and then the sacrum and coccyx are all fused. Next, we have our shoulder girdle. Each shoulder girdle supports one of our arms. It consists of our collarbone and our shoulder blade. The collarbone is probably the most commonly fractured bone in the body. So it's important that we understand that with that collarbone, a lot of the movement of our arm can further exacerbate it. So remembering that when we start talking about our splinting. Our shoulder girdle then continues down into our upper extremity. We have our humerus, and then our radius and ulna, and down into our hands. Next is our rib cage. There are 12 sets of ribs. They create a protection around our vital organs, including our heart, our lungs, our liver, and our spleen. Each of these ribs are attached to the spine in our back, and then they come up and are attached to the sternum by cartilage in the front. The only exception to those ribs that come around and connect to the sternum are the 11th and 12th rib, which we call floating ribs. And they're called floating ribs purely because they do not connect in this, purely because they do not connect to the sternum in the front of our chest. Continuing on down the body, we have our pelvis, which links the upper body and the lower body together and protects our abdominal organs and our which protects our abdominal organs and our reproductive organs. The lower extremities are then attached to the pelvis. Our lower extremities consist of our thigh bone, which is our femur, which is the strongest and longest bone in the body. And then our lower leg is the tibia and fibula, moving down into our ankle and foot. And our ankle and our feet, just like our wrists and our hands, are composed of many smaller bones that help us do the articulating motion, and each of those bones can be injured as well. Next, we're going to talk about the muscular system. Muscles of the body provide the support for movement in working in conjunction with our skeletal system. Our muscles are attached to bones by tendon, and they cause the movement by alternating contraction and relaxation of different muscle groups. The movement occurs at joints, where two bones come together. At those joints, we have ligaments that hold the bones together. And so at joints, we can have either tendon damage from where muscles are connected, or we can have ligament damage where the bones are connected. But we also need to remember, and we'll talk more about this as we go into splinting, that any articulation at a joint can cause injury to the muscles and bones above and below those joints. We have different types of muscle within our body. We have our skeletal muscle, which is a voluntary muscle that attaches to the bone and makes it so that we can actually move. These are contracted and relaxed at will by us thinking about it. We then have our involuntary muscle, or our smooth muscle. This is in our digestive tract and some of our other internal. This is found in our digestive tract and some of our other internal organs. We don't have to think about these muscles moving. They just naturally do their movements. The final type of muscle that we have is our cardiac muscle, and it is only found in the heart. So when we start talking about musculoskeletal injuries, it's important that we understand the mechanism of injury. And the mechanism of injury is just however the patient was injured. So we're looking at direction of force. So we want to look at whether this was a direct force, an indirect force, some type of twisting motion. So we want to look at whether this was a direct force, an indirect force, or if it was some type of twisting motion. We can start gathering information about the mechanism of injury long before we ever make it on scene. This is part of that scene size up. We want to gather as much information as we can from our dispatch information. Then when we arrive on scene, this is when we're taking in everything that we can see. We're looking at the vehicle location or the location of the patient in conjunction with a ladder or a roof or anything that we can take in from the scene to help us understand how that patient may have been injured. All of that information that we gathered leads to the most important part of our job, which is providing the best assessment and treatment that we can for that injury. So there are several types of injuries that we can deal with. The first one that we're going to talk about is fractures. Fractures are anytime there's a break to the bone. This can be either an open fracture, which means that the skin is open and the bone is sticking out, or it can be a closed fracture where the bone is broken but there's no break in the skin. These are caused by significant force. Our bones are pretty strong, so the force needed to actually fracture a bone is going to cause injuries not only to the bone, but you're probably going to see injury to the soft tissue and the muscles surrounding that as well. When our bone breaks, there's a shearing force, and often the bone can have sharp fragments and often the bone can have sharp pieces or fragments as well that risk cutting blood vessels. So we need to be aware that there's often bleeding associated with fractures as well. The next type of injury is where two bones come together and there is a disruption of the ligament at that joint. So both ends of the bone separate completely from each other, and that causes the dislocation, and those bones will lock into a position where they're no longer in contact with each other. Any attempt to move these can be extremely painful. There is also the same risk associated with fractures, where now that those bones are out of place, there's a risk that we can shear any of those blood vessels. So it's important that we stabilize any dislocations. So it's important that we stabilize any dislocations so that we're not causing further damage to our blood vessels or to nerves. Next, we have our sprains, which are joint injuries caused by excessive stretching of the ligaments. So strains are ligaments. So Sprains are ligaments, and then strains are caused by stretching or tearing of muscle. Signs and symptoms that we're going to be looking for with any of these extremity injuries, they're going to be painful. We're often going to see swelling or discoloration as the soft tissue and the muscles above those bones or joints have also been injured. Our patients are normally going to be self-splinting or have the inability to move the injured extremity, and they're going to be tender or painful to the touch as well. As with all of our patients, we want to assume that there is a risk for spread of disease, and we're going to make sure that we're taking standard precautions. So as with all patients, we're going to make sure that we have gloves on if there's an open wound and we're going to be in contact with bodily fluids. Also remember that if we're responding to a traumatic scene where this injury has happened, whether it be a motor vehicle crash or some other hazardous scene, we want to make sure that we're wearing appropriate PPE, which could include heavy rescue gloves to make sure that we aren't being injured by any broken glass or other sharp objects that may be around. As always, if there is any active bleeding or potential for blood splatter, we want to make sure that not only are we wearing gloves, but that we are wearing mask and eye protection as well to make sure that we don't get any of the patient's blood into our mouth or into our eyes. As I said at the beginning of the chapter, all of the steps of the patient assessment need to be carried out before we actually start treating an injured limb. So we need to make sure that we're gathering a good general impression of the patient. We're stabilizing their airway, breathing, and circulations first. However, if there is a limb injury that has excessive life-threatening bleeding, then that does need to be treated immediately prior to moving on to the rest of our assessment. We talked about in our we talked about in one of our other chapters the need for no. So if you do have excessive bleeding, we can use a different algorithm. Instead of our airway, breathing, and circulation, we can do HABCs, which is hemorrhage first. So making sure that we're stopping any major bleeding and then moving on to airway, breathing, and circulation. It doesn't do us a whole lot of good to work on airway, breathing, and circulation if the patient is going to bleed out and not have any blood to carry the needed oxygen and nutrients around to the body. Once we have gone through our general impression and taken care of our life threats in our ABCs, then we can go ahead and start doing a more focused inspection of the limb. As we're doing this inspection, we want to compare each limb we can go ahead and start inspecting the injured limb. As we do this, we want to inspect opposite limbs so that we can see if there's any differences in size or rotation from the injured limb to the non-injured limb. We want to see if we can notice any open wounds, any swelling or bruising or deformities, different angulations to the bone or joints that may indicate that there's an injury. As we said earlier, there's going to be tenderness if there's a fracture. This is one of the best ways that we can tell that there's an underlying injury or dislocation if it's not readily visible when we inspect. So to check for this, we're going to actually move down the patient's limb, slightly pushing pressure against it to slightly pushing pressure against our hands as we move down. That puts a little bit of pressure on the bone. We'll be able to see if there's any movement in that bone or joint that shouldn't be there, as well as if we do that and as we're squeezing, we will be able to have the patient elicit a painful response and let us know if there is any tenderness. As you're conducting this hands-on examination, as you're squeezing and feeling for any movement, the location of the greatest pain is likely the spot where the injury is. If there are no signs of injury, as you're going through your assessment, you can ask the patient to carefully move the limb and see if there is any pain with movement. If there is an injury and the patient starts to move it, or if they refuse to move at all because of pain, then you can be cued into injury as well. As I mentioned, with fractures and dislocations, there's always a risk that we are going to disrupt the circulation or the nerves that are around those bones. So we want to check for circulation, sensation, and movement in every extremity. And this is something that we should do on all of our patients as we move through an injury assessment. All we're going to do is some simple checks. We can check for circulation by checking either for a pulse in that extremity or by checking for our capillary refill. If you remember, our capillary refill is simply squeezing either the fingernail or the toenail and making sure that the blood has gone out of it. And as we let go, we see how quickly the blood returns to that limb. We want that to be less than 2 seconds. 2 to 4 seconds would be a delayed capillary refill. So we can check circulation that way. We check sensation by just asking if they can feel us touching. I like to ask them which finger I'm touching or if they can feel me touching. That is a good indicator of sensation. And then the next one is movement. We simply ask them if they can wiggle their fingers or toes. Oftentimes they're not going to want to move their entire arm, but it normally doesn't hurt too much for them to wiggle their toes or a single finger or toe. Any of these limb injuries that we find, we're going to go ahead and treat similar. We want to make sure that we cover any open wounds with dry sterile dressings. If there is bleeding, we need to stop that bleeding, whether it is putting direct pressure on there or if we need to move to more or if we need to move to applying a tourniquet or some other way to control that bleeding. If they are having any pain, we can also use ice packs. And then we always want to splint the injured limb, making sure that there's not excessive movement as we're preparing them for transport to a medical facility. The reason we want to splint is it creates The reason we want to splint is it prevents any excessive movement of the broken bone or the dislocation. And as we said, we want to make sure that there isn't excessive movement so that we don't damage any of the blood vessels or nerves that are surrounding those bones. It also prevents further damage to soft tissue. This in turn is going to help us control bleeding. It's going to also help to relieve some of the pain. A lot of that pain is from the movement of those bones. And so if we can splint it and put it in a position of comfort for them, then it'll make it more comfortable as we transport. As we're getting ready to apply our splint, we want to remove as we're getting ready to apply our splints, we want to remove excess clothing from around that injury so that we're able to fully inspect the wound, making sure that there's no open wounds associated with that fracture, making sure that we're able to see any swelling or bruising that may be present on that extremity. We want to make sure that we note the presence of our pulse, our circulation, and our sensation and movement prior to any splinting, because we're also going to check it after each splint to make sure that what we did didn't cause any further damage to the patient. If there is an open wound, then we want to make sure and cover that prior to applying the splint as well, as that open wound can cause damage to the splint depending on what kind of splint we are using, and it's going to create further pain for the patient if we don't cover that up prior to splinting. If possible, prior to moving your patient, you want to make sure and do any splinting so that you're not excessively moving them with this broken or dislocated bone that's going to start rubbing against each other. As we start thinking about principles of immobilization, I want you to remember that no matter what, we're going to splint above and below the injury. So if we're splinting a long bone, then we want to splint the joint above and below that long bone to make sure that we don't have any movement. Or if we're splinting a joint from a dislocation or something, then we want to splint the long bone above and below. So remembering the anatomy, where our bones are, how they articulate, becomes really important as we think about how we are going to apply our splints. There are many different things that we can use to create a splint. Really anything that There are many different things that we can use to create splints. All we need is something that is rigid, that is going to reduce movement in that joint or that bone. There are commercial devices such as these SAM splints. They are a moldable, malleable, they are a moldable kind of aluminum splint. They have aluminum inside. You can also use cardboard, you can use sticks, you can use pretty much anything. The great thing about emergency medical responders is they are extremely resourceful and they're able to look around, see what they have near them, and able to create splints from just about anything. Sometimes we don't want to use rigid splints, and in those cases we may use soft splints. A lot of these soft splints are inflatable or vacuum splints that are kind of a clear plastic. They can be really good, and a lot of EMS services carry them. It makes it so that you're able to see through that plastic and continually observe the injured site, making sure that there is no further damage. They can also be damaged if there is an open fracture though. So they are made of plastic, and so if there is bone sticking out of the extremity, they can puncture that plastic and then they no longer hold their vacuum. And then they no longer either hold the vacuum or the air that is helping splint. Another thing to think about when using vacuum splints or air splints is they're size dependent. And so if you have somebody who's too big or too small, or they're too large to fit around these splints, then they're not going to work. So a lot of times your rigid or aluminum SAM splints are going to work a little bit better. I like these because they're so versatile, whereas if you have a pack of vacuum splints or air splints, they take up quite a bit of room and each one has a specific purpose, but you're not able to be as creative and flexible with your splinting. The next splint that we will talk about is our traction splinting. This is going to be for our lower extremities, specifically our femur. We have these really big bones that are surrounded by extremely powerful muscles, and as they break, they're going to create that shear and cause damage to the muscles and the blood vessels and the tendons, or cause damage to the blood vessels and nerves that are around them. And so the idea behind traction splints is we're going to pull those two bones until they come in alignment. So they're not on top of each other anymore, and they're not causing any more damage by rubbing against each other or rubbing against muscles. Applying traction splints require multiple people. We're going to go through it today, and I'm going to show you how to apply it with one person if that's all you have. It really just depends on your equipment and the personnel you have. We always need to remain flexible and adaptive as emergency medical responders. Looking at splinting specific injury sites, if we are splinting the shoulder girdle, we want to make sure that we are preventing any movement. So remember, above and below the joint. So making sure that we have immobilized the arm And then as we try and immobilize above that joint, it's difficult because it really is the top of everything. So we want to use any triangular bandage or clothing that we can use to make a swing, to make a sling, holding that arm in a position of comfort. And then we want to wrap another one around. We call that a swath, just to make sure that the arm isn't going to rotate out and cause any further injury to that shoulder girdle. We would do this if we had any shoulder dislocations. We would be doing these slings if we had any shoulder dislocations. The other thing that we want to keep in mind, though, is most people don't have their arm tucked into their body all the time. There is a little bit of a gap. And so as we're creating that sling for people, if we have a rolled blanket or a pillow or something that they can place between their arm and their chest wall, it will create a more anatomical position of comfort for our patients. Next would be our elbow injuries. If we have an elbow dislocation or injury, we want to try and splint in the location that we've found it. And so with these, remember, we're splinting above and below. So we're making sure that that joint isn't going to move. We can wrap the elbow using a pillow or some other type of padding, making sure that our fingers are exposed so that we can continue to assess that circulation, motor, and sensory. Pillows are great as a padded splint, but once again, our malleable splints can be used for anything in the arm, including our elbow, our forearm, our wrist, and our hand. So next, we are going to take a look at splinting our forearm. There are several different types. Like I said, anything that you can use to make sure that that forearm isn't going to have any excessive movement. We're making sure that we're splinting the joints above and below. And we're going to take a look at splinting using our SAM splint on our volunteer today. So we've got our volunteer Logan here with us, and we're going to go ahead and look at splinting a forearm. Remember, we want to splint the joint above and below any injuries. And so we're going to take our splint, and it's important that as you're getting your splint ready, you want to make any adjustments and measurements on the uninjured arm prior to moving to the injured arm. Just for this demonstration, though, I am going to show you all on one side so that you can see it. There are many different ways that you can use these splints. I wouldn't say that one way is right and any others are wrong. Just whatever you can do to make sure that you're following the basic principles of splinting, remembering above and below the injury. So if we were looking at a forearm injury and we need to stabilize that elbow, so one of my favorite methods is the sugar tongue method. And for this one, we're just going to bring it up along the patient's arm. As you can see here in the back, it is holding that elbow in place, comes along the arm. These splints get their rigidity when they are folded a little bit. So we want to make sure and roll it in. And as we roll it in, you can see that is a lot more rigid than this side. So we'll do the same thing on both sides. Like I said, this is what you would be doing on the uninjured side, is creating that form that is going to go around the patient's arm. So then as you bring it in, You can mold it around the wrist as well. Because remember, above and below the injury. So once we have that in place, then we could use once we have that in place, we'd be able to use something like an elastic wrap or Curlex or anything else that can hold it in place. I like to start in the middle. Remember the above and below principle, but we also want to be able to check a pulse on these patients. So I'm going to want to be able to get my hand in and check the pulse. And then we're going to need to be able to check to make sure that he still has motor and sensory in this extremity. So we're not going to want to cover the entire hand either. And then remembering that we're securing the elbow as well. So you'll go up around. And that way the forearm is secure. We're not going to have excessive movement in the elbow or the wrist. We're still able to check for a pulse. And with every splint that we're going to do, we're checking for pulse, motor, and sensory. So I'm making sure, can you wiggle your fingers? He can still wiggle his fingers. Can you tell which finger I'm touching? He can tell which finger I'm touching. So we're going to assess that every time we do a splint. So that would be if we are splinting a forearm. The next one that we would be doing, and is very common, is if we're splinting a wrist. And if we're splinting a wrist, then we need to stabilize the forearm and the hand. And so for these ones, you can do the exact same with your splint. Just create a little bit of a bowl in there that makes it rigid. And then I like to roll up the end. So we want to try and leave every joint in as close of an anatomical position as we can. And so it's not common for people to have their hands straight out. So if I were to place this on Logan and had his hand out flat, that wouldn't be natural. Normally our hands are a little bit curved. If you think about holding like a roll of quarters or something, that's more natural. So we create that curve or that roll in our splint. And so we would be doing the measurements and everything on the uninjured arm, coming over to the injured side, and hopefully it would all fit. We would have that roll there, and then we would do the exact same thing as before, using our elastic wrap or our Curlex or whatever we had to hold that in place. Following the same principle, I want to be able to check my pulse there, so I'm not going to wrap around the wrist so that I can still reach in and check the pulse. We also don't want to cover up his fingers completely because we want to be able to check that he can still move those. And then we would secure it there. I can reach in, I can check for a pulse, and we can see if he can move his fingers. So these SAM splints, these malleable these malleable splints are excellent. We can follow the exact same principles if we are splinting a foot. You could make that same sugar tong and put it around the patient's ankle, wrapping up their lower leg. They're not fantastic if you're trying to do an entire leg, but if you were trying to stabilize a knee and you had two of them, then you could stick them on either side, sticking them on the side of the patient's leg, and that would help stabilize the knee as well. So these splints are great. They can be used in many different ways, and they're probably my favorite of the splints that we have. There are skill drills available looking at applying air splints and the vacuum splints as well. I do not have any, but if that is what your agency is using, make sure that you are familiar with them.
Cool.
Sweet. It's like 2 slides and then we're at the femur. Hand, wrist, finger, we talked about that just now. As we move down and start talking more about the lower extremities, we want to pay attention to any possible pelvic fractures. Pelvic fractures can bleed quite a bit, so these patients we want to we may be treating for shock based on the signs and symptoms that we see of an elevated heart rate, rapid breathing, low blood pressure that lead us to think that there is some type of internal bleeding. We can check the pelvis by feeling for tenderness. We want to compress in on the pelvis, not necessarily out. So it shows both here. It shows pushing down and pushing in. If there is a fracture, you'll be able to notice tenderness by pushing in, and pushing in will actually help hold the pelvis together. We want to try and avoid pushing down if at all possible. So first try in on the pelvis. If there is no pain, then we can try a slight down pressure to see if they complain of any tenderness. We can also have hip injuries or dislocations, and we can also have hip injuries or dislocations. The hip dislocations are very common, especially in elderly patients. These can result from either high injury traumas or from slips and falls in our elderly population because they have weak bones and they become more fragile with age. Any of these, we just need to immobilize them in the position found using pillows or blankets. These are the type of patients that we are going to want to put on a long spine board for movement purposes, as we're trying to keep that in line as possible. Next is our femur fractures. We've already talked about these very briefly, that they are such a large bone and they become unstable. And as they become fractured, the two pieces will actually slide on top of each other. And that sliding motion is causing damage to the surrounding tissue, the blood vessels, and the nerves around there. So for these, we want to place our patients in traction. And so now we're going to have our volunteer come back up, and I'm going to show you one type of traction and how it can be applied. Now remember, when applying traction, normally you're going to want to make sure that you have 2 providers. So this isn't going to be exactly how it would be if you were doing it on a patient, but you'll be able to see the principles of it. So there are many different kinds of traction splints. This one is one of my favorites, as they are light and compact. They're just kind of like tent poles that pop together. So any of these splints are going to have different securing devices to make sure that it is secured to the leg after you have placed it on your patient. And they should all come with some type of foot stirrup so that you can wrap it around the patient's ankle and that's going to be what pulls and actually creates the traction. As with all of our injuries, as we're getting ready to set this up on a patient, we want to make sure that we do any measurements on the uninjured leg. One of the reasons I like this traction splint so much is you can actually make your measurements and adjustments on the side of the patient without actually manipulating their leg at all. So it works really well to be able to measure even on the injured side. So as you're setting up your traction, you're going to want your assistant or your other provider to be pulling traction on the leg. And so you're going to start out, oh, come on. You're going to start out with your partner grabbing around the ankle and just pulling down on the leg until there is pain relief from the patient. And now they are going to be set holding that position until you are done applying the traction. With this traction device, we have a strap that goes up around the hip. So this one is going to go in between our patient's legs and come up along the side. The adjustment that we're going to see on this one, we want to make sure that it extends far enough past the foot that we're actually able to pull some traction down. So we don't want it right up against the patient's foot, but we also don't want it too far away, as that is just going to create too much, trying to get the right word. As that can create a hazard as you have excessive length sticking out from the patient. So for my volunteer Logan here, I'm probably going to shrink this down. There goes mine.
It's so hot.
That's all right. I think that camera. Oh, but mine has the sound.
With the other off, mine picks up just fine. And that one's actually picking up pretty good too.
Okay.
Or we can plug that in. I mean, it should be fine.
So now that I have made sure that it is the right length for our patient, I'm going to go ahead and connect the straps up at the top. Like I said, this is a lot easier with 2 providers, or even more if possible. We're going to open up that foot stirrup. It's going to go around the ankle. It is secured with Velcro. I might actually need that longer on you.
Also going to tighten that down. So once we have everything tight, then we will begin pulling our traction. And this is just pulling until they have relief from the pain. Can you feel the traction being pulled?
Yep.
Once you've pulled enough traction, you want to make sure that you secure that in place so that it doesn't release the traction. And then you'll go through and finish securing the patient's leg to your traction device using the securing methods that you have. This one has the included Velcro straps. And there you have a traction splint. Once again, it's important to make sure that you are familiar with whatever device your agency is using and you have practice with it. Each one is a little bit different, but the principles of applying a traction splint are the same across the board. We want to make sure that we have one provider that is pulling traction while we are setting it up, and then we set up our traction, pull traction until we have relief. Some traction devices actually have a meter on them that shows you how much traction is being pulled. If you do have one of those devices, then the rule of thumb is we want to pull 10% of their body weight. So if our patient weighed 100 pounds, we would want to pull 10 pounds of pressure in our traction. As mentioned, if we are splinting a knee injury, we want to make sure that we are splinting it in the same position that we found it. If the knee is straight, we can use long padded boards or air splints. We can also use two of our SAM splints together, making sure that we're immobilizing above and below that knee injury. If the leg is not straight and there is significant deformity in the knee, then we may need to use other bulky soft paddings to splint these patients, finding either pillows or blankets or whatever else we have to splint it in the position that we found it, and then securing it to the uninjured leg. So all of these splints that we're doing, we can, so any of these leg splints that we're doing, we can use the other leg as that rigid support, making sure that the other one isn't moving. It's the exact same with our ankle or foot injuries. As I mentioned with our SAM splints, we can use these to create that sugar tongue and put our foot in there, making sure that we don't have any movement of our ankle or foot. We can also use pillows or blankets or any other soft splints that we have. Practice is the most important thing with trying to think of new and creative ways that we can splint extremities.
making sure that as we're going through and doing our continuing education, we're thinking about things that are around us and trying new ways to splint and seeing if we can create a good immobilization of joints and long bones. It really does take about 2 people to adequately put on any splint. One person can do it if the patient is alert and able to help out and not in too much pain. But really, you need somebody who is supporting the extremity and somebody else who is applying the splint. Next, we're going to talk about head and spinal cord injuries. If we have any of these head or spinal cord injuries, they can lead to paralysis and permanent brain damage. So we want to make sure that we are treating them carefully and we're following our local protocols and guidelines for their treatment. The human skull has 2 main parts. We have the cranium and then our facial bones. As you can see here in this picture, the cranium is composed of the fused bones that fuse as we grow into, or as we grow out of being an infant. And then our face has our eye sockets, our nasal bone, our upper jaw, and then our lower jaw. The cranium holds our brain. And so when we think about the mechanism of injury, we need to understand what's happening inside of the skull. So we have the bone itself, and then there's a thin layer of fluid that encapsulates the brain. And then we have a thin layer of fluid that encapsulates the brain and helps create a bit of a cushion. Any direct force to the skull can cause injury to the brain as it is moved back and forth inside that hard enclosed space. There are different types of head injuries. We can have our closed head injuries. This is where there is internal bleeding and swelling from the brain, and it's creating pressure against the skull. These are life-threatening, and we can see that the brain, as it begins to swell, starts to look for other places to go, and the only opening is at the bottom of the skull, and it will start forcing the brain out, causing herniation. Another type of injury would be our open head injuries. These are normally going to bleed profusely, and they are easily treated by direct pressure on those wounds, as long as we don't have any fractured or open bone fragments as well that we need to pay attention to. We also need to examine the nose, eyes, and ears, looking for any blood or any of that fluid or that cerebral spinal fluid that surrounds and protects the brain. If we see anything suspicious for cerebral spinal fluid, then it could indicate that there is a crack in that cranial vault and that fluid that is used as a cushion is leaking out. Actually being able to identify cerebral spinal fluid is very difficult. It is a clear fluid. They teach that you can take a 4x4 or some other gauze and dab the blood, and if there is cerebral spinal fluid, because it is oily, it will separate out from the blood and you will see a halo of a clear fluid or a yellow fluid around the blood on your 4x4. This doesn't always work, but it is a good way that we can test to see if there is any cerebral spinal fluid in the blood coming from our nose, eyes, or ears. A little more about our closed head injuries. With our closed head injuries, we can have multiple injuries associated with it. As there is an impact to the skull and our brain begins to move inside that cranial vault, we can have injury to both sides of the brain as it moves forward and backwards inside that vault. Signs of head injury that we're going to be looking for are going to be confusion, any unusual behavior. If there's any loss of consciousness, we need to note if there was and how long there was a loss of consciousness for, and if they did regain consciousness at any point. We also want to pay attention to any nausea or vomiting, any unequal pupils as we're looking at their eyes. Seeing if it's reactive to light, we can tell if they are equal or not, or if there has been any seizure activity. Serious head injuries, we may start to see what are known as raccoon eyes or battle signs. Raccoon eyes are where we start to see excessive bruising around the eye, making us look like raccoon. Battle signs is bruising behind the ears. Our treatment for head injuries is we want to immobilize the head in a neutral position, making sure that we maintain an open airway using the jaw thrust maneuver in these cases, being prepared to suction any vomit as we are now having the patient laying flat on their back and we're limiting movement. If they do become nauseous from this head injury, we need to be able to suction and clear their airway. And then we need to be able to support their breathing. And be prepared to perform CPR if necessary. With any of these head injuries, we want to gather as much information as we can. This is when we're going to try and determine whether or not there is blood or any of the cerebral spinal fluid coming from any wounds in the nose or ears. We're going to try and control any bleeding, but most importantly, if we have any severe head injuries, we want to arrange for prompt transport and make sure that they are getting to a higher level of care as quickly as possible. Along with injuries to the cranial vault and the brain, we can also have injuries to the face. These are often seen in our motor vehicle crashes where patients are either hitting the steering wheel or the windshield. We often see them in assaults. The other that is very common and a pet peeve of mine is when people drive with their feet on the dashboard and then the airbags deploy. Not only are you going to see lower limb injuries, but what happens as that airbag deploys, the knees come back into the face and cause extensive facial damage. With any facial injury, it's important that we make sure and maintain an open airway, as there can be swelling, there can be a lot of bleeding that is now going into the airway. So we need to be ready for suction as we are maintaining that airway. Treating facial injuries, we need to assume that there is also an underlying head injury. So make sure that we're maintaining the head in a neutral position and opening the airway using a jaw thrust maneuver, as long as there is no injury to the jaw itself. We want to make sure that we are supporting their breathing, controlling any bleeding from the face using dry, sterile dressings, and arranging for prompt transport. If you're unable to keep the patient's airway clear, then you may need to log roll the patient, allowing them to let the secretions drain using a modified recovery position, as we are still trying to keep these patients in as we are trying to keep these patients' spine in a neutral and inline position. Moving down from the head, we're going to talk about the spine and mechanism of injury for the spine. When we're looking at these injuries, it can be a displaced vertebrae, it could be swelling or bleeding that is causing the spinal cord damage. In severe cases, the spinal cord itself may be severed. If all or part of that spinal cord has become severed, then we lose the ability for nerve impulses to travel from the brain to the parts of the body below the point of injury. Injuries to the spinal cord that happen high in the neck can paralyze the diaphragm, resulting in the inability for them to breathe and ultimately death. We can see some of these high spinal cord injuries from gunshot wounds that enter into the abdomen and travel and hit the spinal cord at that same level. We also see them from falls or motorcycle accidents. One of the most common with these is going to be diving into shallow water, causing spinal cord injury as the head impacts when you're diving into shallow water. When we are looking at our motor vehicle crashes or our motorcycle accidents, we want to look for we want to look for high speed, high energy accidents that can cause that spinal cord trauma. So we're looking for motor vehicle accidents that had speeds greater than 40 miles an hour. If it is a motorcycle accident, it can be speeds greater than 20 miles an hour. And then as we're looking at the vehicle and looking at the damage that has been caused to the vehicle, if there is any vehicle intrusion into the passenger compartment greater than 12 inches, then that would be indicative of a high injury trauma. As you're assessing for these spinal injuries, you're going to have the patient rolled on their side. You're going to be feeling the spine, checking for any tenderness over any point on the spine or neck. You may also notice weakness or tenderness or paralysis, loss of movement in any of the extremities. You might even feel deformity on the spine as you're doing your assessment and feeling down for any of those points of tenderness. Another sign that they may have spinal cord injury is either a loss of bowel or bladder control, and we can also see with these patients something known as a priapism, which is an erection associated with a spinal injury. Our treatment for these spinal injuries, we want to place the head and neck in a neutral position, trying to stabilize their head and preventing further movement. We need to maintain an open airway with these patients. Instead of doing the head tilt chin lift method to maintain an open airway, for these we want to use the jaw thrust maneuver. making sure that they have a patent airway, that they're breathing, we're assisting their breathing if needed, and administering oxygen for them. With these patients, we want to assess their pulse, movement, and with these patients, we want to assess their pulse, movement, and sensation in all of their extremities. Remember, we talked about checking it in the extremities that we were splinting earlier, but with our spinal injuries, we want to check and make sure that it's present in all of the extremities. And that way, if there is any movement and they lose it in one extremity or the other, we are able to share that information as we are doing patient handoff. Once you have immobilized the patient and you have them in a natural, neutral, in-line position, then we can go ahead and do a further examination and treat any other injuries that we find, making sure that we are arranging for prompt transport as well. In some of our spine injuries, they're going to be associated with impacts from either sporting events such as football or motorcycles or snowmobiles or dirt bikes, in any of these cases where people are wearing helmets. So it's important that we understand the process of removing those helmets and also keeping the patient in a neutral inline position. So I have welcomed back our volunteer Logan again. We're going to talk a little bit about helmets and helmet removal. The only time we are going to remove a helmet is if the helmet is blocking their ability to breathe, or if we're unable to maintain an airway. A lot of times these helmets are fit very snugly to their head, and so they're actually providing a lot of protection for us. So if you can remove a face shield, if they have one, that will help. If you're talking about a football helmet, you may remove the face guard prior to removing. But when we absolutely have to remove a helmet, it's important that we try and maintain their head in as neutral a position as possible. And so with these patients, we're going to want to make sure that we remove the straps. If you're being nice, you will actually take the time and remove them. If it is an emergency situation, I have cut straps before, though it does make people very upset when you do that to their helmets. As with all of our splinting and moving and doing different things, this works a lot better with two people. So I'm going to talk through kind of the positioning of each person. So one person, you're going to want to actually be holding the helmet and manipulating the helmet. The other person is going to be wanting to be on this side of the patient and maintaining the stabilization of their neck, making sure that we don't have excessive movement. So at this time, you would have somebody supporting the neck, making sure we don't have too much movement. And with these helmets, you're able to take them and rock them forward a little bit. And as you rock forward, you'll be able to get your hand underneath and support their head more. And then you can pull back from the top, slowly removing it off of their head. Like I said, these are very tight and they fit snugly. But as you do that, your hand will be on the back of their head, supporting their neck. And then that movement backwards doesn't cause excessive movement into their spine. Next, we'll talk a little bit about injuries of the chest. So fractured ribs can produce a lot of pain and difficulty breathing at the site. They are often associated with underlying injury to the organs that are being protected by those ribs.
So it's important to pay attention to which ribs are injured, the points of tenderness, and then what might be underneath each of those ribs. One way that we can determine whether there is an actual fracture or break to these ribs versus just some bruising is you can apply pressure to another point on the ribs, not necessarily right over top of the ribs. So if the pain is more in the front, we could put pressure on the back side of those ribs. As we're putting pressure on the back of the ribs, if it is a bruise and it's soft tissue injury, then it's not going to have as much pain. But if we're pushing on a different part of those ribs, it's going to push those two broken pieces against each other. And as they push against each other, you're going to have pain and tenderness in that location. Splinting of rib fractures is basically just putting a bulky dressing over it. We can use pillows, trying to prevent excess movement, and administering oxygen and treating their difficulty breathing. For more severe rib fractures, we have what's called a flail chest. And a flail chest is two or more and a flail chest is when 3 or more ribs are broken in 2 places. This creates an entire section of the chest wall that will move independently of the rest of the chest. These flail chests decrease the amount of oxygen and carbon dioxide exchange in the lung. They're extremely painful, and the way that we splint them is very similar to how we're splinting some of our other chest, is very similar to the way we are splinting our other rib fractures. So we want a big bulky dressing on there. Often these patients are going to have decreased work of breathing anyways, so we want to make sure we're not restricting any movement any further of the chest wall. It may be beneficial for these patients to support their breathing using if we support their breathing using positive pressure, using a bag mask device and supplemental oxygen. As we create that extra pressure, it helps the lungs expand a little bit, and it actually creates a splint from the inside against that flail segment. If we do have a flail segment or even a single broken rib, we have the potential of a penetrating chest wound or something else that has punctured the lung at that point. Anytime we have a penetrating wound into the chest wall, that can allow blood or air to escape and could ultimately lead to collapsing of the lung. Anytime we have one of these penetrating wounds where we have blood or air escaping, we need to quickly seal it using an occlusive dressing, administer oxygen, and arrange for prompt transport. If there is an impaled object still in the chest, we want to make sure that we're not removing it. If we remember, any of those impaled objects can actually be slowing the bleed or tamponading it completely. And if we remove an impaled object, it can cause the bleeding to become worse.
So in summary, our musculoskeletal injuries are caused by three types of mechanisms of injury. We have direct force, we have indirect force, or twisting forces. Fractures can be either closed, where the bone is broken, but there's no break in the skin, or we can have open fractures, where the bone is broken and the skin over top of that break is lacerated as well. Dislocations are a disruption that tears the supporting ligaments around a joint. Sprains are a joint injury caused by excessive stretching of those supporting ligaments. And the basic types of splints that we're going to use for all of our fractures, dislocations, and sprains include rigid splints, our soft splints, and our traction splint. Severe head and spinal cord injuries can result from many different kinds of trauma. These traumas are common causes of death, if not fatal. They may lead to irreversible paralysis and potential brain damage. Injuries of the head are classified as either an open or a closed injury. In a closed head injury, bleeding and swelling within the skull increase pressure to the brain, leading to invisible brain damage, leading to irreversible brain damage. An opened injury is a head. An open head injury usually has profuse bleeding associated with it. When a sign or symptom of a head injury is present, immobilize the head and stabilize the patient's neck. Make sure we are maintaining an open airway, supporting breathing, monitoring circulation, and determine whether or not there is any cerebral spinal fluid present in the blood if we are able to. We want to make sure we're controlling any bleeding from the head using dry, sterile dressings and treating any other serious injuries, all while we arrange for prompt transport for these seriously injured patients. When you suspect a spinal injury, try not to move the patient during examination and do not allow the patient to move themselves. When you have signs or symptoms of spinal injury, make sure that we are placing the patient's Make sure that we are placing the patient's head and neck in a neutral position, stabilizing the head and preventing further movement of the neck. Make sure that we're maintaining an open airway, supporting their breathing and monitoring circulation. We want to make sure that with these patients, we are assessing for our motor circulation, and with these patients, we want to make sure that we are assessing for pulse, motor, and sensation in all of the extremities, not just the injured extremity, and making sure that we are arranging for prompt transport. Most common chest injuries that we're going to see are involving rib fractures, flailed chests, and the penetrating traumas. All right, our review for this chapter: musculoskeletal system refers to involuntary muscles of the nervous system, connective tissue that supports the skeleton, bones and voluntary muscle of the body, nervous system's control over muscles. And the answer for this one is bones and voluntary muscles of the body. When examining an injured extremity, you should be sure to A, manipulate it in different directions to determine where fracture might exist. B, keep it elevated at all times. C, splint it to reduce movement before continuing the assessment. Or D, squeeze the entire limb starting from top in a systematic, firm manner. And the answer for this one is, while we are examining, is D, squeeze the entire limb starting from the top in a systematic, firm manner. And our last question, facial injuries should be identified and treated as soon as possible because bleeding is more obvious in the face, patients are always concerned about their face, swelling may mask hidden injuries, or of the risk of airway problems. And the answer for this one is D, the risk of airway problems. All right, guys, that's another chapter down. We're doing great. I'll see you in the next chapter.